Charles Miller, the Director of Health and Economic Mobility Policy with Texas 2036. You guys have probably heard me talk about this before. Usually what I'm trying to do is channel information from almost all of the witnesses that we have here today. These two folks are sources that I use all the time, and so if you have any hard questions about the data that I'm going to bring, I'm just going to punt it back to them.
Nice.
The root problem of what we're here for today is that we're spending too much on healthcare, and the numbers and the indications of this are pretty clear. It's 18% of our GDP goes to health spend. It's $5.3 trillion. And on the individual level, that's $27,000 for that health insurance premium. That's a lot. And it's so much that voters, for the first time ever, are saying this is their number one priority. From a selfish policy wonk kind of position, this is great. You guys want to hear from us, and it's wonderful. But the polling is very clear on this. We launched a voter poll last fall, and this issue was more important than property taxes, than homeowners insurance, than disaster response, than water infrastructure. These are all the topics that have been taking up a lot of time at the Capitol, and health affordability is more important to Texas voters than all of them. This cuts across partisan lines. This is the number one issue. This was reinforced by Cynthia's group's poll recently, just in April, that the affordability of health care was more of a worry than the affordability of gas right now. That's how big of an issue this is to the people at large. So the question is, why do we spend so much? And economists have had the answer for quite some time, and it's boiled down to the seminal paper on this, which is titled, memorably, "It's the Prices Stupid." What does that mean, though? I've been wrestling with this just by way of personal background as to why I got into this. I am a recovering attorney. I am 8 years litigation clean, hoping to stay out of that. I got into this world because pricing made no sense to me in healthcare at all. We saw this in litigation, and I kept asking why, and I never got a good answer, so I kept reading everything that I could read about this. What does it even mean for us to say it's the price is stupid, and that's the reason why we spend so much? When we think about why we could spend so much on something, we could think about, well, how much of it are we consuming? So are we just consuming more of that thing, or are we spending more at a unit level? And if we're spending more at a unit level, is that because the underlying cost of making that thing has gone up? Or is it because just the prices that we're being charged are higher and they're untethered to the actual cost structure? So I think that we can answer some of these questions. You've heard about comparisons to other countries. I think the other country evidence is good. It is indirect evidence. When we look and see how much do we spend as a nation as a percent of our GDP compared to other countries, and it's much higher, that is suggesting that accounting for the potential cost differentials, we are still spending more. That is suggesting that it's prices. But we also have more direct evidence of this. And you're going to hear from some folks from Nashville later today. But the most direct evidence that we have of why it is prices and not the underlying costs of things comes from when we look at what commercial payers are actually paying for healthcare to hospitals. And on average in Texas, that's about 2.5 times what Medicare spends. And you compare that to what hospitals say when they report to the federal government they would need from commercial payers in order to break even, which in Texas is about 127% of Medicare. That is a pricing differential that is not tethered to their underlying cost structure. It is twice as much as they would need. Now, I'm not here to say that Medicare is the appropriate rate to pay. I'm not here to say that break even is the right need. You need to have profit. You need to have room to build up reserves. You need to have more than that. But when the prices that we are paying are twice as high as they would need to be for that break even, it suggests that pricing itself is untethered to the underlying cost, and the total amount that we're spending is untethered to the amount that we are utilizing the service. So why is that?
And just to be clear, who gave the price, the break-even data? Is that something you're?
So yeah,
I thought you said it was self-reported by the hospitals.
So this is a great question. I'm going to answer it shortly, and then one of the witnesses who is here today is great to talk on that detail more directly. If you switch to page 5 of the handout that I had, this actually has kind of the chart here. But the National Academy of State Health Policy evaluated Medicare cost reports. And Medicare cost reports are submitted by hospitals to the federal government and includes a lot of information about their cost structure. What NASHB did that was really clever is they looked at a hospital's entire reported cost structure and their entire reported revenue structure, and then tried to isolate out, just for commercial payers, that's people who have commercial health insurance, what they would need to receive in payment revenue from commercial payers as a percentage of Medicare, just for a nice baseline evaluation, in order to break even on their reported costs. And that is what we call that commercial break-even number. And that's represented on this chart here. Every dot on that chart is an individual hospital's commercial break-even number. On the right-hand side, and we have a witness here who conducted the study that brought this as well, Christopher Whaley, is the amount that employers are paying to a hospital for those services. Again, as a percentage of Medicare, just for a nice comparison basis. And those bright lines in the middle are the median statewide for what we have data on. This is the evidence to me that is pretty clear that we have a pricing failure where our prices are completely untethered to the underlying cost structure. And this suggests to me that the root cause of it's the prices is the failure of our market to adequately provide that discipline to bring those prices in line. When we think about this, what is it that we need for a healthy market to function? And we kind of think of this as three aspects of it. A market to function, you need it to be informed. So this is, it needs to be transparent. People need to have the appropriate information in order to make decisions. You need to have competition. You have to have choices. You can have all the information in the world, but if you don't have a choice to act on it with, you just know how badly you're getting hosed. And this is kind of that college textbook example. And the last thing is it needs to be accountable. You need to have the right incentive structure set up, and those incentives need to be aligned so that everybody is working towards the same goal. Those are the three big factors. When we talk about informed and transparency, that's where a lot of the attention has focused. State has done good work. There's still problems. Employers report difficulty getting access to their own data in order to make the decisions that they need to make on behalf of their employees. A lot of price transparency efforts have been going out. There's progress there. There are still widespread reports of usability, maybe lack of compliance in some scenarios, but the usefulness of that could be improved. When we talk about consolidation and competitive lack of choices, there's going to be a lot of folks up here today talking about how consolidation has occurred, and that has happened both horizontally, meaning you have mergers of hospitals with hospitals, insurers with insurers, doctor groups with doctor groups, but also vertically. And that's where you have different aspects of the system buying up different parts. And that vertical integration now really starts to talk about maybe more of the misaligned incentives. When you have vertically integrated units, you now have a situation where the opportunity for misaligned incentives compounds. This misaligned incentives, I think a lot of us intuitively understand when we're working with somebody else whose incentives aren't aligned with us. The real problem occurs when we give someone else to make discretion to make decisions on our behalf, and they don't have the same incentive structure we do. If somebody else has the authority and the discretion to make those decisions that will impact us, and we think that they have their own personal motive for doing something different, this is a breakdown in the system. And that breakdown of incentive structure is everywhere. You're going to hear a lot about that from different witnesses today, but it is rampant at every part of the healthcare structure. Some of it's unavoidable. We pay for our healthcare primarily with insurance, which is inherently a third-party payment system. There is almost no way that you can get around that because certain instances of healthcare are just too expensive for any one person to afford, and so we have to pool that. There is some amount of that discretion that has to be placed. But now when we introduce 17 other different middle layers, and that 17 number is perhaps an exaggeration, but perhaps not, there are too many components of the chain who are not ultimately accountable back to the end of making sure that the patient's interests are at heart. And so that complexity compounds the problem of misaligned incentives. So as we go through the next couple of days, I just want you to keep those three concepts in mind. And that is this problem related to a lack of information, that the people involved in making these decisions don't have enough information to make that informed decision? Is it because we don't have enough choices, because things have consolidated too much? Or is it because there is an incentive structure that is misaligned, and we need to think about how to solve that problem due to misaligned incentives?